Hello and welcome to Health Matters on Channels Television. We are glad you could join us. I am Mary Alale Yusuf. A resurgence of diphtheria in Nigeria started in December 2022. In the NCDC situation update for the end of June, more than 800 confirmed cases and over 80 deaths were recorded. Confirmed cases are reported across 8 states. Diphtheria is an acute bacterial disease caused by toxin-producing strains of Corynebacterium diphtheriae. The name of the disease is derived from the Greek diphthera, meaning leather hide. In the expanded program on immunization, where vaccines are administered free of charge, DPT is given, and D stands for diphtheria. Diphtheria is considered one of the deadliest childhood diseases. Joining us on the program from our Abuja studio is public health physician and director, Global Health and Infectious Diseases Control Institute, Nasarawa State University, KEFI, Dr. Akiala Ishaku. You are welcome, most welcome to the show.
Thank you, Mary, for having me, and good afternoon, viewers.
Why is diphtheria surfacing at this time? I was so surprised the first time I heard it. I'm like, diphtheria? We've dealt with that. Why are we hearing about it and then getting even more cases?
Yeah, why are we having it is a very big 1 million question. This is because in the 21st century, we are not supposed to be battling with vaccine-preventable diseases like diphtheria, pertussis, and tetanus. But Mary, you will agree with me that during COVID, there are a series of lockdowns. There are a lot of pregnant women that, give birth, and they could not be able to access the routine immunization. So we have children within that category of more than a year plus that mix the vaccination. And so you have more cases like this resurfacing because a lot of people, there is a kind of a suboptimal vaccination program as a result of mixed children that have missed vaccination. Mary, this thing will still resurface because you know that the insecurity that we are battling with has to do with a lot of people migrating from one point to another, and then with a shrink shelter. And you know that one of the predisposing factors for this diphtheria disease, which is airborne, is overcrowding. So you go to IDP camps, you see people being overcrowded. You go to places like cities where you see a lot of people conglomerate, come together, and then, people actually, this disease get transmitted among populations that clusters together. So why are we having it now? We are having it because of the multifactorial indices that plays key role in disease transmission. Mary, I was also thinking that in the 21st century, we should not have it. This is because for every child that is giving birth, we should have a database. Like a collaboration between the National Primary Health Care and also the National Population Commission, where we have a database for children that are giving birth, even in remote places, so that once a child missed immunization, we should be able to know it from our database.
Okay, let me quickly come in there.
We need to
let me quickly come in there. Yes, a database and all that, but is it not true that there are some people who don't even come for immunizations? People you don't have on your database or you don't have in your register because they didn't even give birth in a facility. Are they not those people?
Absolutely. We have people that did not even come for antenatal care, did not attend antenatal clinics. We have people that give birth, but they are not being captured. But traditionally, Mary, you know that we have traditional birth attendants. If you build their capacity, build capacity of people, community-based kind of advocacy, and begin to bring them, integrate them into decision-making for vaccination programs, I think it will go a very long way. I was somewhere in Tanzania last year where in the remote places where you do not even have internet facilities, people still live in hinterlands. Once a woman is giving birth to, a traditional birth attendant has a way of transmitting such kind of data to the national database. It is quite key. We can also roll out programs to serve as a prerequisite conditions for virtually everything. Mary, what stops us from having a vaccination card that can be with a batch code, that for every child that you'll be dropping at a crèche, you'll be dropping at a nursery school, you'll be dropping at a primary school, must be able to present their certificate, vaccination certificate. This will go a long way to be able to handle most of the missed children that we have. And time has come for the National Primary Healthcare Agency to begin to focus more, have a paradigm shift from looking at the environment with a microscopic view and looking at institutions where also children clusters. It will be good for us to begin to have focus now on our schools, most especially at crèche and nursery and primary schools, where we should be able to cohort them into our vaccination framework and begin to see how they can be target centers where we should be able to administer vaccines. Just like the way we look at churches, just like the way we look at mosques, just like the way we look at traditional institutions being integrated into a faith-based organization and traditional institutions being integrated into decision-making as stakeholders, we should be able to think in the direction of schools. This will go a very long way.
It would be very unfair for people to be gathered in school, and because of one or two unvaccinated people, everybody begins to come down with diphtheria. But let me ask you about this leather hide appellation of this disease. What is this leather hide referring to? What does this diphtheria do to the body?
One of the clinical signs and symptoms, the name diphtheria is a Latin word. And the height in the skin is what you just mentioned now, is that it has a clinical presentation. So you have erythema, the skin begins to coalesce together. It has an outlook as if it is an eczema. Those are the presentations. So in Greek word, it is called diphtheria, while in Latin it is called diphtheria. And so it is a characteristic feature of how the skin looks like. But by and large, you're beginning to see the clinical signs and symptoms ranges from fever, which is virtually associated with most of the diseases. But what is quite peculiar is that the tongue and the throat becomes inflamed, and you begin to see some whitish layers being formed. And then there are issues of tonsillitis, inflammation of the tonsils, and also the nasopharyngeal. So diphtheria is a disease of the upper respiratory tract. It also leads to difficulty in breathing. But one of the clear symptoms that you can see, which is quite visible, it is that of the skin.
So we are saying here that a child virtually suffocates on this disease because his airways are blocked?
Absolutely. Airways are blocked, so he finds it very difficult in breathing. It is not only associated with children, Mary. Every age group is affected. But people that are more vulnerable, studies have shown, research have shown that people that are more vulnerable are children between the age of 0 to 14 years. And so one of the clinical signs and symptoms is that it takes one to a state of finding it very difficult to breathe. And then there are also breathing seizure. And then you find out that those are the clinical signs and symptoms that are being presented by this disease.
Okay, you pointed out several reasons why diphtheria is now coming up. But before the COVID-19 vaccine, before the COVID-19 pandemic, rather, and when the DPT was being given regularly, we weren't hearing about diphtheria, really, were we? So on the strength of just that vaccine, is it enough to handle the situation?
Absolutely. So you have also concurred to what I said. Before COVID, you discovered that there are a lot of vaccine uptake. One of the studies I just read of recent about, vaccine hesitancy when it comes to diphtheria is that before COVID, there is high intake of DPT, which is a pentavalent vaccine. People take those vaccines because it prevents from most of the childhood killer diseases. So the uptake is very high. But Mary, we experienced series of lockdown. A lot of pregnant women could not even access antenatal clinic. A lot of pregnant women could not also access the vaccines. And so post-COVID, we now saw the outbreak of diphtheria, which is quite unusual. But what we would have done is to actually manage our vaccination program, immunization program during COVID. If we had a very robust database, people would have been clustered in communities and vaccine would have been given. Quite key vaccines would have been given that would have prevented, or if we had a database for all the pregnant women, either on our database or in community. But after COVID, we now saw, COVID came with a lot of misinformation. COVID came, in fact, it was during COVID-19 that people said that vaccines are not potent. There are a lot of heresy, there are a lot of myth, there are a lot of misinformation regarding vaccines. And so vaccine uptake drops. And then that's why we are seeing more cases of diphtheria. But as we begin to march towards post-COVID era, we are going to be faced with a lot of outbreaks of diseases. This is because we have fractured a health care system, and then we also have a lot of children that have missed vaccination during COVID. What the National Primary Health Care needs to do...
Is there no way, at least to put out some information there, that for those who have missed vaccinations because of the COVID era, they should come and take up the vaccinations, that it's not too late to get preventable vaccines? Because these vaccines on the EPI are vaccines that have been accepted. They were there before COVID. So what could the problem be? Mothers have been giving their children these vaccines to prevent diseases. Can't the Ministry of Health bring out jingles or something? Information. If you missed your vaccinations, your children missed their vaccinations, come back and get them. I mean now that people have more or less lost their fears about COVID-19.
So I agree with you. What we need to do is to do a robust, strategic, targeted advocacy so that we can be able to target the population of people that needs to take these vaccines. We need to also target caregivers. But Mary, we need to move also beyond advocacy and begin to attach certain, I don't know what to call it now, but for example now, if a woman is pregnant and she has given birth, it will be good for us to also be distributing children parts to women at their postnatal clinics to encourage them to actually do vaccine uptake. I've read about research in Ghana, in Kenya, and some African countries where such kind of strategy stimulates vaccine uptake. Because beyond taking vaccines, what are the kind of benefits that caregivers derive, apart from preventing their children from vaccine-preventable disease? So is it possible for us to come with a strategy to begin to stimulate caregivers, to begin to stimulate vaccine uptake among a population and begin to give them incentive? I am quite happy that the money that will be used for as a palliative for I think it is 8,000 naira per household for this fuel subsidy removal palliative. Why can't we look at the holistic component of it and have an indices that goes to health and begin to target population of women that comes for antenatal care and also do after antenatal care and begin to see whether we can be able to give them incentive. It is quite key. If you tell a woman in a rural community that if she comes to take vaccine, she goes home with 500 naira, they will come out. They will bring their children to take vaccines. So beyond looking at advocacy, which not all people have access for advocacy. I think resources should be channeled towards stimulating caregivers to bring their children for immunization.
Okay, we know that diphtheria is a deadly disease. Let's say somebody already has it. Can the person be treated, and how much time does the person have? What's the window of safety?
Actually, diphtheria is a curable disease. It's a disease that can be treated because most of the signs and symptoms can be handled. But if you are looking at the recovery rate of an individual, it depends on his immunological status. So the immunological status of a child and an adult may not seemingly look the same. In fact, I've read also from literatures within a population where people that have a very high immune status, or their immune system is quite, high, this disease is even self-limiting. Maybe perhaps me and you, Mary, might have had an encounter with diphtheria for quite a long time, but our immune system was able to handle it. So if you are looking at the survival rate ratio, if you are looking at the recovery rate, it depends on the immunological status of an individual and his also nutritional status and the social well-being.
Let me cut in there.
Those are the factors.
Let's go on a very quick break and we'll come back and continue the conversation. Please stay with us. We're coming in a moment. Welcome back. It's Health Matters on Channels Television, and we're talking about diphtheria. You can contact us during or after the program by tweeting at CTV_Mary A, or by email moalale@channelstv.com. Now let's continue with the program and find out more about this disease. Doctor, now we were talking about survival rate and how much time a person has. What I really want to know is when a person comes down with a sickness, not, the asymptomatic type. The person comes down with an illness. How much time does the person have to respond and get well?
Okay.
How urgent is it?
So what we have is that we have what is called an incubation period. An incubation period is the time that the infectious agent, the etiological agent, get into a host, stay into the host, multiply, and then there are outcomes of signs and symptoms. Now, when these symptoms manifest and then you go into treatment, for diphtheria, the incubation period is between 4 to 5 days. But the recovery time, in terms of understanding when the person undergoes treatment or is placed under a treatment regimen, it ranges between 5 to 7 days. So it is expected that once you place someone on treatment, research have shown that between 5 to 7 days, one should be able to recover from this disease. So we have an incubation period and also have a post-recovery period when treatment is being initiated of 5 to 7 days.
Does it leave anything behind? Is there any incapacity of the patient after recovery, something that the patient loses or can no longer do after an infection has been treated?
Very, very rare. Very, very rare if we have. But research have shown, I've read about some research, not among Caucasians in the US, that it leaves a kind of a skin defect reaction. Research have not shown much studies that are done in Africa to actually have some dermatological post-treatment regimen effect, but it shows among Caucasians. So this also opens a window of opportunity, Mary, for us to actually dig deep into doing a lot of research. You will discover with me that and there are no much research that has been done on vaccination around diphtheria here in Nigeria. So I think our scientists need to do more in understanding what is the vaccine efficacy, what is even the hesitancy rate, attrition rate in terms of vaccine uptake. We need to do a lot of studies to unravel even our genetic makeup, our cellular immune system response to most of this. Is it adequate? And for how long will these memory cells of our immune system will last in an individual? Those are the kind of things that we should, as a country, be able to look into and young researchers be able to venture into. So
Definitely.
I agree with you that this conversation will go beyond what you are trying to stimulate in the minds of young researchers coming up so that we can also think deeper. But for now, there are no effects in terms of a post-effect, in terms of treatment regimen or other issues that are left behind. That has been established because there are paucity of information among blacks or among Africans.
If we were talking about cholera now, for instance, you would tell us, wash your hands, boil your water. The bacterium comes from dirty water. But concerning diphtheria, what do you tell a community that has diphtheria? Does cleanliness help? And where does that bacterium come from?
So you asked a very valid question. Where does the bacteria comes from? So, you know, Mary, we are in an era of One Health where you need to look at the human population, the animal population, and the environment. Have we successfully established that this organism comes from human? Yes, it is from human, but there is also human-to-human transmission, and that's why you have outbreaks. But have we established whether this bacterium can also be transmitted from human to animals or animal to humans? Have we done studies to actually see if this bacteria can also be isolated from environment? Yes, that has been established. So if the bacteria can be isolated from environment, can be isolated from human, what about animal population? Can our medics within the veterinary doctors, can they be able to look at this and begin to establish whether within animal population, diphtheria, so that it will enable us to be able to handle our pets, our domestic animals well. Now, you made mention about cholera, washing of hands and all what. Most of these diseases that are communicable, they are being transmitted from one person to another, seems to have similar preventive measures that are quite non-pharmaceutical in nature. So we talk about staying in ventilated areas, avoid overcrowding, just like COVID, just like tuberculosis. So if you're passing message for tuberculosis, you are still passing the same message for COVID, you are still passing the same message for influenza, you are still passing the same message for diphtheria, because these are airborne diseases. So you are passing message for airborne diseases. We need to also see to how we are in a post-COVID era where we have thrown away our masks. But I think that vulnerable populations, people should be encouraged to be wearing their masks. And that's why you go to countries like Japan, you find out that it has become a norm for a Japan citizen, even if he's in Nigeria, to wear masks, because it is part of their what will I call it? Like part of their style, their dressing style, to wear face masks. So I encourage people within community not only affected by diphtheria to have a proper sanitary and hygiene outlook. We must be able to keep our environment clean. We must be able to see to how potable drinking water should be provided. We need to also cultivate the habit of washing our hands thoroughly in a running flow water, and then rinse it, and then begin to see how we report cases, not only for diphtheria, but begin to report cases of outbreaks of diseases. And when people are sick, we must be able to see to how we improve their health-seeking behavior. They should be able to report to a nearby primary healthcare center, and then they should be attended to. So that if there are diseases of public health importance, if there are diseases of public health emergencies, they should be able to be notified, and then such kind of people can be placed on quarantine and in isolation. So that is the way to go.
Definitely. Thank you so much for all that information. And I'm so glad that you mentioned that people should not be ashamed when such a situation arises to wear their masks. Thank you so much for coming on the show, Dr. Akiala Ishaku, Director of Global Health and Infectious Disease Control Institute, Nasarawa State University, Kefi. Thank you for coming on the show.
Thank you, Mary, for having me, and thank you, viewers.
Thank you so much for being there with us. Let's do it again another time. Have a wonderful day. I am Mary Alale Yusuf.